Hello and welcome to the Evidence for Change podcast. This is a new podcast series that exists because patient engagement has no shortage of evidence, but far too little of it actually changes how care is designed, delivered, or experienced.
Great to be here, and we thought it was a great opportunity to get like-minded people together to talk about patient engagement and the evidence and also the application of that. So, we're going to dive into topics such as, can these programs be sustainable? Can they make a difference where they can actually sustain the cost of running them? Can you really design and roll out a global program? Can you measure these solutions effectively to demonstrate value? So that's the intent of the Evidence for Change podcast. Maybe just to kick things off, so I'm Johnny Duda, I head up Atlantis Health, been with Atlantis Health 22, 23 years, building out patient engagement strategies and solutions, which has been the combination of how do you take behavioral science and then use that insight and those frameworks to develop a solution that can be refined through a co-design process with all of the actors in the healthcare system, patients, care professionals, to be able to add value to all of those stakeholders, which is what you need. And then how do you use technology to personalize and scale and measure? Mostly working for life sciences, pharmaceutical companies to help them optimize outcomes. Yeah, it's a really intriguing space. I love it. And hopefully I can bring some of that 22, 23 years of doing it to the table. And I hand to Charles to introduce himself.
Thanks, Johnny. Hi, everyone. My name is Charles. I am a clinical research professional. I've been in the clinical research space for the last 12 years. I'm really interested in the transition from an idea, a scientific idea, into testing it through the clinical research or scientific process, and then getting that out into the market. It's really interesting because this podcast series sits at the limit of my conceptual understanding at the moment. I'm looking forward to learning more over the process and these conversations with the likes of Johnny and John, and kind of be the advocate for the audience to learn about these really interesting topics and how we are, there's a lot more value out there to be obtained by users of healthcare or providers of healthcare. And this series should certainly provide that.
So I will now introduce John. Our relationship in terms of Atlantis and John goes back 20 or so years. And so John has 2 decades, more than 2 decades of really understanding patients and how they see their treatment, how they see their illness, and how that then impacts on their behavior. So that's my introduction of John, and John can now introduce himself.
Thanks, Johnny. It's good to be here. My day job, if you like, is I'm Emeritus Professor of Psychology applied to medicines in King's College London, and I have a long-standing interest in patient behaviour, patient self-management, treatment adherence, and so on, going back over 30 years now, and have really enjoyed working with Johnny and Atlantis, putting that knowledge, as it were, into real-world practice.
Yeah, it's been good fun. We thought it'd be great to kick this series off with sort of, I suppose, the uncomfortable truth that John has just recently about, which is, in 2003, the WHO published really, I think it was the first time the WHO had sort of come out with the topic of non-adherence to sort of quantify the issue and the impact that it was having globally on healthcare outcomes. And I remember when this came out, and there was quite a lot of noise around it. And, it really was seen as the authoritative account of the extent, the causes, and the effect of non-adherence. So it actually laid down quite a good blueprint for the problem and what's driving the problem. Since then, there's been a lot more research done. I think there's been a lot more evidence that's built that gets to starts pinpointing what the problem is and how you go about addressing it. But what John's recently published in an editorial piece in 2025 sort of basically said, even though this was released 20 years ago, what's happened? What's changed? And we haven't seen the needle moved really around what was called at that time sort of a major health crisis. And so I thought it'd be good to get John on to really talk about the fact that there is evidence that has been built, but why haven't we seen the needle moved, particularly around non-adherence, which has a big impact on pharmaceutical industry, a huge impact. For the impact that it does have, it just doesn't seem to be getting the traction or the acknowledgement within pharma, but also in the healthcare systems.
Yeah, it's a big challenge. And I think really there's some fundamentals here. One of the fundamentals is that I think systems have not really understood adherence as a behavior and there's a behavior that goes through various stages. So adherence is at least a three-stage process. People have got to begin treatment, which a lot of people don't. They've got to fit that treatment into their daily lives, and they've got to stick with it over time. And adherence or non-adherence can occur at each of those levels. And so I think that's one problem, that it's a complex behavior with a sort of sequence of processes with different issues that are important at each level. I think the other thing is, that generally healthcare systems have failed to understand that adherence is actually driven by many, many factors. Now, the traditional view is that adherence is all about forgetting or lack of knowledge, which is a factor, but it's probably not the factor. There are many other really important factors, and I think key amongst those are the actual individual motivations of the patient, how much they really want to take the treatment. And that in turn is very much driven by their beliefs about their condition, their beliefs about the treatment, the sort of worries or concerns they may have about the treatment, and also about their emotions. I think patient emotions play a huge role in driving their behavior. And so because of that very traditional view that adherence is just about forgetting, which it clearly isn't, I think the sort of interventions that people have brought in have been quite naive. They've just been reminders or provision of information to, make people aware about the importance of their treatment, and they, perhaps little reminders and so on, particularly in the digital space, a lot of reminder apps now. And those really have pretty minimal effect. They only really work if that is the fundamental problem. And for many patients, it's not the fundamental problem. So in a sense, what we have a lot of evidence now on the behavioral science side about what adherence is, what causes it, but we have this sort of implementation gap. That evidence is not being used in day-to-day practice, either by pharma or by healthcare systems. And I think, both pharma and healthcare systems have sort of really struggled to embed this behavioral science knowledge, and certainly the science of behavior change, into sort of routine practice and day-to-day practice. And so, we're still in this situation where adherence is sort of treated as if it's a patient problem. Patients forget or they don't care or whatever. Or sometimes it's treated as if it's a failure of healthcare professionals to really communicate clearly about, the treatment, so on, rather than a sort of a failure of system design or a challenge to system design. And systems fall short in a whole lot of ways. Adherence support is rarely built into, the commissioning of healthcare or quality frameworks that are used to evaluate healthcare. So, even at that level, at that very top level, it's not part of the piece anymore, or still is not part of the piece. I think also people who provide day-to-day clinical practice have pretty limited training in behavioral science. I think there's often a failure really of clinicians to either understand the nature of non-adherence or to have the skill to really take it on, to be able to discuss it in a way with their patients and to support better medicines use. And also there's quite a problem out there in terms of just routine assessment. Very rarely is adherence or non-adherence assessed routinely in healthcare, or it's done in a very consistent and quite limited way so that, patients are either classified as being adherent or non-adherent, not in terms of where the problems lie, what's driving the problems. And there's very limited assessment of the different drivers, these really important drivers of non-adherence in, routine day-to-day healthcare. And so, the end result of all this is that, healthcare systems, pharma recognizes and rewards the importance of prescribing and treating disease, but actually supporting the behaviors that make the treatment work is something which is pretty well neglected still. This is the fundamental failure in many ways.
Well, what I find interesting about this topic, particularly coming from a pharma background, is that, you spend all these hundreds of millions of dollars developing a new drug, and it's tested in an incredibly tight and restrictive environment, and accountability of the drug and adherence to the drug is critical, right? Because you want to make sure that patients are taking it. And you've got all this evidence on the basis of that, hopefully 100% adherence, and then it goes out into the market, and then there's a massive gap in terms of a patient's actual uptake of a drug. So you've got this real world evidence, which is different from a clinical trial evidence, which surely, I mean, that must be quite a delta between what you're expecting a patient to experience on a new innovative treatment and what they actually get because of this adherence issue.
I think interesting thing is, Charles, because we work a lot with pre-launch treatments. And so the first, we're looking at that clinical trial data and you can see the problems. It's not like, and this is even within the clinical trial, you could see the dropout rates. You can see, it's not necessarily what they won't pick up and what we think they should be is understanding the why the profile of the patient's perceptions around treatment and illness going into that clinical trial and understanding it particularly when they drop out, because that would inform the design of your program. But that is not done. The other bit that's interesting is you can see these issues in the clinical trial. Yet there's just such a big divide between the pre-launch, all that effort, like you say, that goes into capturing that clinical data. They capture a lot around the challenges, but it doesn't then inform, or there's not a lot of investment typically to go and try and address those or get ahead of those problems in the real world. So yeah, we've got a long way to go on that. And John, it's really interesting, those topics. Before we kind of maybe move on, I think you've done work. What's been interesting, the work you've done with clinicians, right, in this area. I think there's always a couple of interesting stories you always tell when you go to these forums with clinicians and you sort of talk about this topic of non-adherence, and then you ask the audience, about non-adherence and the incidence of it.
Well, I think one of the things you're talking about, Johnny, is what I sometimes do at a conference with a large group of clinicians, where I try to get them to say what they think the extent of non-adherence is. And usually they're not too bad. They recognize that it's sort of a pretty big problem, 40, 50% of patients quite often on long-term medicines. And that will come up. And then I might actually say to them, well, how about your patients? Do you think, what's the level of non-adherence in your patients? And wonderfully, the problem sort of almost disappears on my patients. So often it's sort of 15, 20% is the figure they give. So it's a really interesting bias in their thinking, and there's a sort of optimistic bias in a way. We all like to believe we're better than the other person, the one next to us. So I think it's partly that, but also, just in terms of the patients who are non-adherent are not the patients they see. The patients who turn up regularly in their clinics and day to day and getting repeat prescriptions, they're the adherent ones they see. So in a way, the data they're sampling from their own experience is biased in that way. So in a way, the teaching and the training we do is very much geared around helping clinicians really understand the ways in which their patients can, if you like, challenge the use of their own medicines and the complexity of non-adherence. So really creating that awareness that it's not just about forgetting the things which I talked about earlier, that patient motivation, beliefs, the situations that patients find themselves in, the environments, the sort of support they get, and so on, that there are a whole range of factors. So getting that as an understanding that adherence is a complex behavior that goes through many stages, that's fundamental. But then the training, the key to training is try to putting that into practice, day-to-day practice. And here we account, there are a lot of issues. Time is one issue. A lot of clinicians say, well, maybe I don't have time to do this. But often it's a lack of skill in eliciting, the challenges that patients are having from the patients themselves. And we've developed quite simple screeners that allow patients to sort of express their own worries or concerns about medicines at the beginning of a consultation to drive a very different sort of conversation. But even when that conversation takes place, I think clinicians feel somehow, well, they're letting the genie out of the bottle, oh gosh, I see this patient's got all these negative beliefs or issues or challenges. What do I do? So a lot of the training now is about providing the skills, the support skills, particularly around behavior change techniques that can be used to focus on the different challenges, because patients have very different challenges. It's not a one size fits all. So, you need to have a bit of a toolbox as a clinician for helping someone who has low motivation or real worries about their treatment, which they may well have picked up from social media and other places. Or the patient who feels very unsupported, or the patient who finds it difficult to plan, and so on. So, really giving them a toolbox to be able to turn that understanding into day-to-day or proper support for that patient that works for that patient. But then the problem there is the systems they work in don't allow them to do that. That at a policy level, there isn't really time and space given for clinicians to do that sort of work. Some pharmacists take it on, which is great, and pharmacists are very receptive to this sort of training. And the other clinicians, nurses, doctors, physios are also very receptive. That's what we find. But they're often working within systems that don't give them the time, the space, or even the recognition to do that sort of work, even though the problem is as big as it is.
John, on the size of the problem, is there data out there that can quantify or has quantified the level of an issue that non-adherence is?
Well, the typical figure that for example, the WHO that Johnny referred to earlier is 40 to 50% of patients on long-term medications, serious long-term conditions, are not taking their medicines in a way that's going to be helpful to them. That they're either not taking them at all, they're not starting, as I talked about earlier, or they're not taking them regularly in a way that's going to make any difference or any real difference to their condition. So that 40-50% figure is pretty widespread, comes and goes a bit. You find in some conditions, but even in very serious conditions, cancers, HIV, really major health problems, you see at least 30 to 40% of non-adherence. So it's massive. I mean, a colleague of mine says it's essentially hit and miss. Roughly half the patients will, half won't. And therefore, we have to take it seriously because, getting on for half the patients are just missing out on the benefits of treatment.
And surely that has a flow-on effect, second, third order effects, people going back to work, income, pharma companies not, dare I say it, making as much money from their asset that they thought they would based on prevalence of a condition or prescribing behavior. So surely there's a numerical value, a monetary value assigned to this issue as well.
Yeah, it's huge, huge. So the health economics of non-adherence have been very well worked out. And the impacts, everybody loses out. The patient, the healthcare system, big pharma, and so on. Everybody loses. It's a sort of a lose-lose situation. But the gains potentially are win-win all round, for everybody. Johnny referred to the piece I wrote earlier in 2025, which is an editorial for a special issue of a journal around the continuing challenge of non-adherence. And one of the papers in that is a huge review. It's a review of 43 systematic reviews. So a really, really important review of the clinical and the economic impacts of non-adherence. And the numbers are eye-watering in terms of economic loss. Yeah.
There is just these interesting industry dynamics where I think it's worth raising because it does point to, I think, why there has been a lack of focus. I think generally there's still in medicines development in the pharmaceutical industry, there's a really, rightly so, there's a strong focus on, treatment efficacy and safety. But actually there needs to be a third pillar in that focus, and that's the real world experience of people taking the treatment and living with a condition. And there should be as much effort put on understanding that and what life sciences companies can do to wrap around the medicine to facilitate that to be the best possible experience that it can be. And I think with that third lens put onto those, you really start to reshape. I think there's an opportunity for life sciences companies to reshape their business models, to reshape the perception that people have of those organizations. And they're in a unique space to do it because the drug development process really follows the journey of a patient. And if you could take that learning and that understanding, and just as they apply amazing science to their medicine, apply the leading behavioral science to what goes around that medicine, I think they could really unlock a whole new business model, and first and foremost, probably just a new opportunity for these solutions. But at the moment is not, for most companies, that's not the focus. There are some that we work with that are fantastic. They see that opportunity. I think for a lot, it's just really a focus on those first two pillars. I think there's just also a bit of an internal, belief that needs to happen that if you, through delivering programs that are designed with behavioral science and you measure them properly, that you can actually, you will deliver enhanced outcomes. We've had a number of clients that we've done that with, and it's really effective. And it's another win-win-win because everyone is winning. Everyone wants better outcomes. Everyone wants better value. So that's the other bit, but that really comes with some internal belief and leadership that these services can deliver that sort of impact. We still see there's a lot of last minute thinking about, we're launching in 3 months, we need to get a solution out there. That's difficult for everyone, including the internal change management within the pharmaceutical company itself to mobilize these programs. So it needs to be baked into the strategy much earlier. And then I think even on the ground, the service needs to be part of the everyday conversation that MSLs and sales reps are having with doctors about the importance of this program, the problems it's solving and the opportunities it's bringing. So it's very much front and center with the clinicians, that where they are not just prescribing a therapy as a therapy, but this behavior change solution as a therapy also. That still is not in the majority of cases, and that takes real effort and commitment for organizations to do that. So those are some of the elements that I think we work with our partners on, but they are holding back the category and they're holding back the industry, I think, from realizing the full power of these solutions.
So I suppose we know the size of the problem. John mentioned 30 to 40 to 40 to 50%, depending on the therapeutic area or the type of healthcare intervention you're talking about, are non-adherent to a therapy. The health economic impacts of non-adherence are massive. There's been a lot of research and evidence on the behavioral science solutions for this. So it's not a patient problem, it's not a pharma problem, it's a design problem or a systemic problem, top to bottom. But we wouldn't be talking about this today if there weren't some actual solutions or some past experience that, demonstrate that this is not a wholly intractable problem. I don't know, Johnny, if you wanted to share some of the examples that your organization have implemented with your partners to illustrate, look, this is, it's a big problem, but it's not intractable, and behavioral science is a great lever to pull on.
Yeah, I mean, one of the examples I think is a really good example, because quite often this is the case where there's a functional service that's in place. So in this case, it's a treatment administration, it's in growth hormone, it's an injection service where the caregivers and the patients have access to a nurse who's supporting them around that administration process. But it was very much a functional design. So what you need to do to administer the product correctly. But they were still seeing non-adherence issues, persistence issues. And what we went into the companies to say is, look, we can certainly enhance this, and we'll address these outcomes by moving it from being functional to a behavior change service. So we'll understand the barriers for each patient or caregiver around their perceptions around treatment and illness that are correlated with non-adherence. And rather than above just giving the functional training on the device, we'll start to deliver some psychosocial support targeted to each and every patient around their behavioral diagnosis that our screening tool did. And over time, we saw that we changed the underlying drivers around non-adherence. We changed the actual non-adherence rates. People dropped from high risk to low risk in a very short amount of time, just through very targeted conversations that were infused with behavior change design. And I think that's a really nice example where we're not talking about, you don't need to re-engineer a whole healthcare pathway. You need to get to patients at the right time, perform this behavioral diagnosis, and then deliver a tailored intervention. And that's where you need to, we don't go to any of these engagements having a channel in mind. We're always just thinking about what's the problem we're trying to solve and where in the journey, and the channel will come to you as a result of that work. So that program is a really good example. I think another good example is the work we did, in immunology. We've done a lot of different projects in immunology. This one was working with AbbVie, which was, developing their global program for Humira. We'll probably talk about a lot more of this in maybe a future podcast, because I think it's still held as one of the exemplars of a program that's gone global that has delivered on all of those sort of big ticket items, right? Outcomes, healthcare utilization reduction. But really at the heart of that program was this, John was actually involved in that, probably the first time a company has ever done multi-market research to quantify predictors of non-adherence by indication across 20 or so markets. That drove the personalization methodology that delivered these fantastic outcomes. And there were different iterations of that program that were scaled to suit different markets, big markets, small budgets, big budgets. But AbbVie were able to execute a program that at the heart of it was personalization. And that was really one of the first times that anyone had done that to the level of sophistication that's needed. So yeah, those are two really, really good examples that demonstrate you take the right science-led approach, you commit to making this a core part of your medicines offering, and you prioritize that. Importantly, within your organization, you can really shift the needle in terms of the outcomes, both patient outcomes and commercial outcomes.
Because I think in this modern day, we're not limited in terms of information, but information isn't necessarily enough to help with these kind of things. You're not going to just barrage a patient who's just had an awful diagnosis with more information and expect a better outcome in terms of adherence or even their clinical experience. So it's for each indication, for each drug, for each program, it's a bespoke strategy, right, Johnny?
Yeah.
It's
Yeah.
from the ground up. To begin with, you got to know your patient, know your intervention, and also know those behaviors.
Yeah, and for us, it's a sort of a circular process where we'll think about what are the outcomes that we're wanting to deliver, which really need to be tightly tethered to the objectives, right, of what is it we're trying to achieve. There will be priority of outcomes. They will look at then underneath those outcomes, what behaviors do we need to address, and essentially from there we'll look to assess patients' capabilities around those behaviors. That drives the personalization, and then within the content itself, it's getting the right behavior change techniques embedded, and then measuring, just reassessing patients around that behavioral diagnosis to look at where do we need to adjust the intervention pattern for that patient. It might be in frequency, it might be in different types of content, different channels. So yeah, you're designing an experience, and that experience needs to evolve with the patient.
I presume with that growth hormone example, because it's such a long time horizon that the patient's taking that medication, that the experience or the behavior or the interventions would have evolved over time as you gathered more data, but also for that individual participant patient as they get older or as their journey as a patient changes.
I think it's a really good point, because if we do our job well, we should be changing, and we see this, we should change the risk profile of non-adherence as a behavior. We can change that risk profile in 3 to 6 months because we change the way they see the treatment, the way they change the illness. And so we'll look and we'll assess on whether that is still a risk behavior. If it's not, the good news is we can still add a ton of value. We can add a ton of value by looking at other behaviors that are going to enhance outcomes. So, it could be once we've dealt with medication adherence, we might be able to help them support around getting more active. It could be more around mental well-being. It could be more around actually just having better conversations with their doctor to talk about their condition. So I think it's a good point, Charles, because I think often that opportunity is missed, where you can move beyond adherence, but there's still a lot of value you can bring to people that ultimately keeps them sticky with the treatment service, and delivers a great experience for them and also back to the healthcare professional. So we've definitely looked to just bake that into the design, that once we've achieved mastery on a behavior, what other behaviors might we want to support to optimize a wider set of outcomes that will drive a better experience and actually commercial advantage as well.
Very good. So I suppose if there's good examples out there for discrete indications or situations, programs. But John, you mentioned that the issue is really systemic. What actually needs to change if we, like we mentioned earlier, we know some of these solutions. The solutions there are precedent. Johnny's mentioned a couple of them just now. Why aren't we able to roll that out further?
I think there needs to be a really strong recognition of the value of the science of behavior change, and that recognition, that understanding needs to be sort of embedded into a number of places in a really coherent way. For example, it needs to be embedded into policy, healthcare policy, both within healthcare systems and also within big pharma, and having that really core acknowledgement and recognition of the importance of the science or the role of behavior and the science of behavior change, both of which are, as Johnny and I've said earlier, really well developed now. But having that recognized at a policy level, I think within clinical training, there's a lot more we could do. Very little, in 5 years worth of training for a medical student, they maybe have 1 hour or something on non-adherence, and it doesn't really hit home. There needs to be a much greater awareness of the nature of non-adherence, the causes of non-adherence, and particularly the development of skills to engage with patients in a way that's going to be helpful to them from the very beginning of treatment. This is not just waiting 6 months until they discover the patient's not taking the medicine. From the very beginning, from the launch of treatment, it's a huge amount one can do to avoid some of those very early adherence problems and the problems of implementing treatment into one's daily life. So I think training of clinicians all around, and I think, the design of services to allow this to happen. These things don't just happen by chance. They have to be built in. There has to be time and space for clinicians, for the clinical team to routinely discuss the challenges that people are having with their medicines, how they change over time, and also particularly in supporting people with those challenges. So I think all those things will make, if we get it right, all those things can make a huge difference to the efficacy of medicines and the potential that medicines have for reducing healthcare problems globally.
If there was one lever that you could pull right now at a policy level, John, that could make the most impact, what would it be?
Good question. Well, I think we should we need to sort of stop treating non-adherence as some sort of patient failure, some inevitable patient failure. There's almost like that's a sort of very negative way of thinking. And we need to start, designing systems around the reality of the behavioral reality of non-adherence and the fact that it's there, it's going to happen unless we do something about it. That 40-50% figure shows it's normal. This is not a sort of patient failure. This is a sort of day-to-day happening. And systems need to be designed in a way to recognize that and to allow appropriate support in whatever form that's going to be effective for that individual patient.
And Johnny, if you could, in your position, if you could wave a magic wand, and so John got the lever, you're getting the magic wand.
Yeah.
You could wave a magic wand to have the most impact. What would that be from your perspective?
I'd probably go for, if I could have two levers.
You can have a lever and a wand. How about that?
Okay. Well, that's good. I don't need much more than that. I think my wand would be, just as we spend so much time in the drug development, why aren't we, developing the treatment experience with as much rigor as that through that process with that amount of time to really help design a solution that transforms the way people manage their condition with the medicine. I think there is enough time and there is enough, amazing people throughout that process, but you bring some behavioral science in to really unpick the challenges and how treatment can support that, but potentially bring some new challenges. You've got an amazing opportunity to develop something that would be transformative. And I think, if I use my wand or onto my lever, because if I'm onto my lever would be, whereas I think that comes to the business model of life sciences, this opportunity to see this third pillar, right, which is, as much as we care about safety and efficacy, patient engagement, patient experience is that third pillar of, that's what's really going to power. Those three things together will power the future of healthcare offerings, because they are all so critical to outcomes. As an industry, that's where we need to be moving towards.
Well, this has been really, really interesting for me as the interloper, the outsider, learning a bit more about patient engagement and patient support programs to improve adherence. Any parting thoughts, John? I think we've run through a lot of it. It's a big problem. It's not intractable. There's solutions out there. There's companies like Atlantis Healthcare that are providing this. Yeah, any final thoughts to really drive the message home tonight, John?
Yeah, I really think if at a policy level, really, there needs to be a fundamental change, and policymakers need not just to be aware of the challenge, but to know that there's a huge amount we can do about that challenge and to get that implemented into the systems they have for day-to-day healthcare.
And Johnny, from your side, any final thoughts?
No, obviously a big topic, and there's lots more scratching to be done on this, and hopefully we can bring other speakers with examples of success, because I think that's what we all need, right? We all need to know that you can make a difference. So, we hope to bring that to the future series. And I think if people have got topics they want us to cover, that questions that aren't talked about or answered in this environment, hard questions, please put them in the comments, and we'll try and get to them and respond to them. But yeah, lots more to come.